Hi, I'm Scott Miller. Welcome to my Top Performance blog. I have the pleasure today of speaking with Professor Sam Malins from the University of Nottingham in England. Hi, Sam.
Hi, Scott. It's assistant professor, but I mean, professor is great, but I'll take it where I can.
Yeah, well, I'm sure based on your publications that a full professorship is coming soon.
I'll take that. I'll take that.
Perfect. Can you tell us
Okay.
just a little bit about yourself before I let people know why specifically you agreed to speak with me?
Yeah. So I'm a clinical psychologist, and I work on clinical practice and research, which is about how to make psychological therapies more effective for people who have both mental health problems and physical health problems at the same time, often using kind of digital tools to help along with that.
So you're bridging both physical and mental health in your work.
That's right. Yeah. Yeah.
And you have been doing some work in particular in the area of routine outcome monitoring or measurement.
That's right. So I led the treatment in a trial of cognitive behavioral therapy, where we were using routine outcome monitoring, but specifically the outcome rating scale and the session rating scale, session by session, to kind of ensure that we were able to offer this as the best we could amongst us as the therapy team.
And I know this is a bit of a sidebar, but it seems as though routine outcome monitoring is on fire in your country.
Yes, yes. So there's a national program called Improving Access to Psychological Therapies, where it's kind of just part of what happens is that you record outcomes at every session. The thing that is brilliant about that is then you get amazing quality of data. So in terms of outcome completeness, it's like more than 90%, which is really high compared to most other services.
Yeah.
Um, but it's very variable as to how therapeutically that kind of process is used. So, as in, you just kind of doing it just because that's what you got to do, or are you using it as a way of making the therapy more helpful for the person that you're trying to help?
And this has been a particular area of interest of yours.
That's right. Yes. Yeah.
And and how to make it more useful, because I think the temptation is, and I know particularly with the ORS and SRS, and something I blogged about not very long ago, was you can download the tools, and of course you know as well as I that we can teach people to use them in 2 minutes.
Yeah. Yeah.
But somehow or other, that leads to a disconnect between knowing how to administer scales and really being able to make much sense or use of them in clinical practice.
Yeah, absolutely, absolutely. So within the trial that this kind of study came out of, we were really aiming to make this as helpful as possible. Like, it's not just a measurement tool. This is something which is meaning that, me and the person I'm trying to help are on the same page. And that's a bit different. And so we're every 6 months, we were kind of having these reviews where we would have like a couple of sessions recorded, review them, and give feedback on how we were doing overall, but also to help us kind of get better. And what we noticed was trends of greater outcome improvement as the trial kind of went on. So we were actually kind of getting a little bit better as the trial went on.
Okay, now I want to make sure I confirm that. And by the way, this particular study, I'm going to put a link along the bottom of the screen, appeared in what is one of the top tier journals in our field. It usually vies with the Journal of Consulting and Clinical Psychology for the #1 position in terms of both impact and difficulty getting into it. So I know the work you went to get it through the review process. I really don't. I know it personally. And it came out in January of 2019. It's called Extending the Use of Routine Outcome Monitoring, Predicting Long-Term Outcomes in Cognitive Behavioral Therapy for Severe Health Anxiety. But you've just said something that's interesting to me, and that is you noticed yourselves getting better at it over time.
Yeah.
Was that confirmed in your data set as well?
So I haven't published, and I didn't have a plan to publish it because there was only 4 of us. It was a small therapy team. We couldn't really say this was a therapist level effect, and we
Okay.
didn't analyze it that way. But it was kind of interesting when you were looking at the way, first 6 months block, next 6 months, next 6 months. There was a pretty clear trend across therapists. Apart from that, there was one who I didn't see as many patients. That you couldn't tell, it was a little bit more all over the place. But for the 3 of us who saw more enough, there was this trend.
Wow.
And so I was kind of interested in that in and of itself.
Well, this
Um,
is, of course, the argument that I and folks at the IECCE may have been making of late, that many of the trials of routine outcome monitoring that find no effect are really not tests of ROM. They're tests of the implementation of ROM. And
yes,
because it's done so early, once again, I think because the measures seem so easy, just apply them and use them,
yeah,
that we really don't see an impact, because we're, as I say, we're not testing ROM in its
yeah.
fullness. We're more testing how much people know about it. Let me ask you, and I know this isn't part of your study, what was it that you think changed for you and your other colleagues that during the process of implementing ROM?
Um, so there's a few. So I guess I'm kind of quite interested in this in terms of future research. I think there were a few things that were going on. One, our group supervision worked that you identified someone who, from routine outcome monitoring, was struggling. There was little or no improvement, or the person closest to that. Then we were doing this therapy over video conferencing. You sent the video of your last session to the group. We reviewed it, and
Wow.
then we come to the session, and you describe what the problem is and what you think is going wrong for, say, about 7 to 10 minutes.
Yeah.
Then you step back. Then the rest of the people in the supervision group. One other thing is we had a medic, and I really feel like that was really crucial. We had a medic in the supervision team, because when we were dealing with medical and physical and psychological problems, that was so helpful, just to say, for her to be able to say, no, it's okay, still do that exposure thing. That is a stable problem. You know what I mean? Like,
Yeah.
our anxiety, it helped allay our anxiety. Anyway, so we discuss it as a team, reflecting on what we've seen in the video, particularly like key skills or micro skills that we thought could do with practice. Then the person who's been listening, it's their case, comes back, reflects on what they're going to do, and particularly on skills that they feel like they need to practice. So that's what's happening monthly. Then 6 monthly, we're actually rehearsing the skills, identifying the things that we think we should be doing more of, less of, whatever it is. So
Wow.
I feel like that was really key to us actually improving. And
So amazing. And I'm pulling out several themes. And the first one was this complete transparency between you and your peers.
yeah, yeah, yeah,
This is enables us to share both our good work and our not so good work, and get the
yeah,
support that we need, because the work is hard. It's not easy stuff we're doing.
yeah,
The second thing is a shared sense of accountability. I heard this throughout everything you said. I had to be responsible. I had to get this stuff so that my colleagues can see it, and I knew that I in turn was going to have to respond to what they were showing me.
yeah, absolutely.
A third is an intense focus. You were
Yes,
very focused, and in particular on looking for the micro skills that you might need to practice more. And here comes deliberate practice,
yes,
which
yes,
which for me is where ROM leads to. It's
yeah,
not about administering these 2 or 3 simple stupid scales. It's really about having the opportunity to pause and figure out, what am I missing.
yeah. Totally agree. Totally agree.
And then
Yeah,
the last thing was, again, is just how super reflective you all became along the way. You were really having the time to think about, what am I doing with this client?
yeah,
And
yeah,
with the workloads that we have today, and I know in particular from some of the news posts out of the UK, the workloads are intense.
mm,
When do we have a time to really think about our work rather than just do it from moment to moment?
yes, yeah, yeah. So I agree, and I have this kind of personal wager that I guess I've been talking about recently, which is that I believe that if you used like deliberate practice time, that the amount of time, let's say you were doing that, I don't know, an hour a week, my my hypothesis is that it would pay for itself within a year or two, maybe,
Yeah, yeah,
because because of the improved effectiveness and efficiency, as in you're going to be getting through your caseload, your waiting list quicker, more effectively. You know what I mean?
yeah,
If you actually focus on things that are going to help you to be more effective, especially if you're kind of starting at average, which most of us will,
yeah.
then it's probably going to mean that you're going to be doing stuff which is going to be better for your service, better for your organization, as well as better for you and for the person you're trying to help. That's my, I mean, it's a win-win, but I hope that would be true, but that, I don't know that. Yeah.
Well, I share the same belief, and I will say that I look forward to seeing that study when you do it, because I think I think it needs to be done. And of course, I agree with you completely. And I know we've kind of gotten a little bit off track from your
Yeah,
particular
yeah,
study, because can you just give us a sense of what you found
yeah.
in the study? And I'm particularly intrigued at some point of hearing what you found about the ORS and in particular, what it might predict for us.
Yeah. So basically, this study was really trying to open up some of the um, spots where there was less knowledge in terms of routine outcome monitoring. So, there's evidence that routine outcome monitoring can make therapy more efficient, shorter. People who are going to drop out, that they might not drop out. People who are going to deteriorate, that they might not. That kind of thing. But oftentimes it was this, so you got this measure, which is the intervention, the routine outcome monitoring intervention, but it also becomes the assessment of whether it's effective or not.
Right.
But I mean, as you say, it's not just doing the measure isn't the intervention, but it's like we're using this, and then this is the assessment of how good it is.
Right.
There were fewer studies which were kind of crossing over to physical health and various other. So there are few studies with long-term follow-up, and fewer studies showing, does this have an effect on quality of life, general health, that kind of thing, or specific mental health problems like anxiety, depression, that kind of thing. So
Right.
what this study did was it took the outcome rating scale at the last session of CBT,
Mm.
and it saw does this predict a range of health measures up to 12 months after that, and measuring that 3-monthly independent by independent researchers across time. So we used a method called multi-level modeling, which helps you to give you a good sense of the trend over that time.
Right.
What we found was that last session ORS, bearing in mind this is a really heterogeneous population, like loads of different, so like an average of 6, meeting the criteria for 6 mental health diagnoses alongside physical health problems, chronic physical health problems too.
So this wasn't just your worried well.
Yeah, no. And in fact, in terms of health anxiety, most people who've got health anxiety also have a long-term health problem. Most people have got good reason to be worried about their health. They're
Right.
very anxious about it. So what we found was that this kind of very ultra brief measure, the last session of CBT, predicted general health, quality of life, health anxiety, general anxiety, depression, work and social functioning, up to 12 months after that measure was taken.
Wow.
So what that means is, if you are doing really well on the ORS at the end of therapy, it's not a bad, and you've got lots of problems going on, it's not a bad like kind of indicator of how things are going to go like several months after that.
Right.
And similarly, if you are really not doing very well on the ROS at the end of therapy, and you are the therapist, it would be presumptuous to think that they might get better after that. They might, but this is suggesting in lots of areas they're probably not going to improve.
Wow.
Yeah, in that way. And what the thing that I really took from it was what a lot of people will in this kind of situation, lots of problems going on, physical and mental health problems, is that if I've got diabetes and I've also got depression, when I go to see my diabetes person, they're not interested in depression necessarily, and when I go to see my depression person, they're not interested in diabetes. But this is a kind of very brief measure which gives you a snapshot of their overall health, no matter what the across lots of problems. So that was the kind of initial bit that we found.
And are you saying then that one of the implications of your study would be that professionals from either group or discipline could use the measure and say, oh my goodness, I've taken care of your diabetes, but I still see that your well-being isn't very good. You need additional help. Is that sort of the implication?
Yes, yeah. Assuming that they are using in a similar way to the way we've been talking about, which is kind of helping them to get on the same page as what using the ORS to kind of gauge what their goals are, where they're heading, that kind of thing. Then yes, that is what it's kind of indicating is if you've got lots of health problems going on, the ORS might be an okay indicator of lots of areas that might be going on. So that was the kind of main finding. And
Yep.
we found an interesting kicker to this in relation to what are called sudden gains.
Hmm.
Shall I kind of just briefly summarize that?
Please, please.
So sudden gains are when there's like a really quick change. So you're measuring the outcome every session, and then suddenly there's like things get a lot better, and they stay better for like a few sessions after that. People who experience those kind of gains generally have better improvements longer term after the therapy's finished. So it's
Hmm.
quite an important thing. Like generally people don't just kind of in linear, it looks like that if you do it all on average, looks like a nice line. Whereas there are clearly some people who very quickly and generally quite early have improved massively, and they will stay well more likely than the people who just have the slow change.
Hmm.
So, but what hasn't really been done is this thing of, you know, if there's sudden improvements on the ORS, is that relevant to other outcomes, and is it relevant long term? And I guess we can say yes, you know, a qualified yes, in
Yeah.
that there was some areas where we identified everyone who had sudden gains, and we said, okay, well, did they then have better outcomes than the people who didn't have sudden gains, who completed therapy? So we excluded all the people who dropped out,
Right.
and they did in terms of general health, in terms of depression, and in terms of functioning. But they didn't. That it's qualified in that they didn't have better outcomes on the primary outcome, which was health anxiety.
Right.
But there were trends for better improvements on every outcome.
Right.
So what it's saying is, if there's a big improvement on the ORS, it may well have like implications for other things that you aren't measuring. Um,
Wow.
yeah.
And if I'm a practitioner and I see this sudden gain, help me understand what that means I should be doing with my client. Is there an implication that you've all thought about? What because I'll tell you, when I went to graduate school, which was
Mm.
back when Freud was still alive, these were called flights into health.
Right. Right.
And of course, if somebody went up, the idea was that soon they would, following Newton's law, come down.
Yes.
But you're saying something different?
Quite different, I think. I think what you would want to be, you'd want to be interested in, hey, something's changed. What's happened? What's gone on over the last week? You want to draw on that, because that can be the fuel for things to keep going better.
Wow.
And actually, it's the opposite of that. Yeah, I heard that kind of hypothesis before. It's the opposite of that is what we'd expect with sudden gains. Is that if you have a sudden, particularly early on improvement, and it stays for a couple of sessions, you're probably going to do pretty well longer
Wow.
term. And I guess I think I've heard you talk about this, that it's either going to stay better or it's not going to stay better. You know, you can't take away that it happened.
Right.
So you've always got that to draw on. It's not, you can't take it away once it's happened. So as a therapist,
Perfect.
it's not a helpful thing.
Yeah.
Yeah.
And you said, or you were hinting that there was some additional study that you're thinking about.
Okay, so I guess this is like really my passion, but I've only, so there's a study in press in the Journal of Psychology, which is clinical psychology, which is coming out, which lays the development of it. But I thought you might be interested in the one that's under review. So
Cool.
I was interested in this study that we've just published, just in and of itself, but it was also the kind of setup for a study which is about giving more detail to outcome feedback, specifically for the focus of deliberate practice. So we developed a tool which rates every interaction in the first 2 sessions of psychological therapy, and also every interaction. So we recording every session. So we pick out those people who had the sudden gains on the ORS, and we say, okay, this has been done before in CBT, but around CBT stuff, we just thought in general, are there interactions that happen, types of interaction that happen more directly before a sudden gain than they do the session before that? So you got, you know, let's say you got 3 sessions. Okay, no big change, no big change, big change. What happens at this session compared to the session before that in
Yeah.
terms of the quality of the if you're looking at it in real detail, like interaction by interaction, rating the quality of it.
Wow.
And what we found was really intriguing. So at that session directly before a sudden gain, but it was significant, the amount of problem description, as in just describing problems or just kind of picking up the context to a problem, but not specifically doing anything with it, no particularly active interactions around it. That significantly dropped directly prior to a sudden gain. In its place were more energized interactions about information, like information giving. I'll give you an example. So I say to someone, hey, so when you're really anxious about going out, staying in would probably make you more anxious. And they say, okay. So I can't tell from that what they've done with it. So that would be like a 0 score. And what would be like a negative score would be if they said, no, I don't think that's true. I think that's totally wrong. But this would be like something which would have scored positive, which could have contributed to this kind of greater score in terms of information giving. So they might say, hey, that's true, because last week when I thought about going out, I stayed in and actually I started to feel more anxious. Maybe that's correct. Maybe I'll do. So there's a kind of adaptation of information that's given by the therapist that's personalizing it to, someone is using their words to personalize it to themselves. There was significantly more of those kind of interactions directly before a sudden gain compared to control sessions.
Are you saying in part that clients are able to recognize in their own life something that the therapist has commented on or empathized with?
Yeah. Yes. Just their first and second session. So these are sessions which we typically think of as just about assessment. They're just, all we're doing is gathering information in that first couple of sessions. And I think this is a resounding no to that being correct. So the question is, can you tell from the interactions at the first and second session how the outcomes that are going to ensue 8 to 15 sessions later on? And the answer would be yes, with certain types of interaction. So I just give you a couple that were really key.
Wow.
Firstly, that this same pattern, the consistent pattern, is that you would expect that, well, from the data that we've used, about 50% of the session will probably still be describing problems. You're not really doing much with it, you're just hearing what the problem is. That's still going to happen. But for about every 5 minutes, more than half the session that you spend just describing problem rather than doing anything else, the improvement on the ROS drops by about 10%. So the more of this kind of just describing problems rather than doing anything more you're doing at the first session, you're going to have loads more sessions, and yet this is important. Then the poorer your outcome is, basically.
Wow.
Whereas if instead of that, what's going on is, well, generally just more active discussions. So maybe a problem analysis, which is more jointly, you only get positive score if the client is actually, actively involved in this interaction. Otherwise it would be like a 0. But specifically, I guess that, again, this is like a study I haven't even submitted yet, but I would say, if I was to say one thing that I think is most consistent, is noticing change, the client noticing change and articulating that at the first and the second session is the most consistent predictor.
So absolutely, and I'm really, really looking forward to that. And I know the people listening will be looking forward to that as well. If people wanted to reach out to you, would that be okay?
Of course, yes, yeah. Email is probably the easiest.
And I'll put that at the bottom of the screen so people can reach out. Sam, I just want to thank you for taking the time with me to talk about your new study. And I know a lot of the listeners will be following your work closely.
Great, thanks for the conversation. I've been enjoyed it, and been quite excited by just having someone to kind of bounce it off with. So it's been good.
Perfect. Yeah. Thank you.
Okay.